So I tend to wander around, so I don't let that distract you. So today I'll try to talk about some efforts we have on this campus around keeping the human in the loop to go towards equitable and fair use of ML in healthcare. And it's our first step, and I'll walk you through our reasoning, and then hopefully we'll have lots of time for questions. So I'll start with a case. So meet Vera. She's 70-year-old, Asian, and has a history of hypertension and asthma, and is now presenting with symptoms of severe pneumonia. It's a fairly common occurrence. And as a primary care doc, not you have to treat the immediate situation at hand, you also have to assess the risk of osteoporosis, the 10-year risk of stroke, maybe heart failure, renal failure, and what else. And there's probably 10, 15 equations to do this embedded somewhere in your EHR, and if you can go through the 25 clicks, you'll probably find them. And they'll work great for 55-year-old Caucasian men, but probably not for Vera. So what do? We talk about precision and medicine and personalized medicine. And for me, at least, it boils down to these two things. We need to estimate the risk of something, some outcome, and if it's above a certain threshold, take some action. And machine learning helps in multiple places. So the risk estimation is either a classification or a prediction problem. Usually a classification problem, less the prediction problem, but we often sort of conflate the two. And then the treatment effect estimation problem, as Sanjay elegantly showed, is not easy. I mean, even in NEJM, for something simple like hypertension, you get two completely opposite answers, especially if you aspire to something called the population-level treatment effect. And I don't know about you, but I don't want to be alive on average. So I would want a treatment that works for me. So I'm rooting for Sanjay to make sure that we get the heterogeneous treatment effect estimations right. And so if all of this worked as advertised, then treatment would be guided by risk stratification to decide whether to treat, and it would be evidence-based in terms of its choice of how to treat. So I'm separating these two parts. And today we'll focus on the first part, which is the estimation of the risk. Because there's lots of effort right now going on ways of estimating or figuring out the choice of the treatment. And Mark Cullen in the morning alluded to something called the Green Button Project, which is something I lead, and where for a bedside consult for a clinician at the bedside, if they ask us about a case, in a day we'll produce a 3-page report of what happened to similar patients. Lots of things can go wrong, and we've put lots of guardrails in place to avoid that from happening. I'll leave you with one intuition. Most of the stuff or associations we find are wrong. So for everything we test, we would ask the clinicians to ideate a bunch of nonsensical associations, like aspirin associating with pregnancy or a drug associating with left foot fracture but not right foot fracture. And then for the data set in question and for your specific question, before asking the question, ask 50 such nonsensical questions. And the rate at which they turn a positive answer, that's the rate at which you're likely to be wrong in your estimation. So it's a very empirical procedure, but that's one of the kind of guardrails. So that's the choice of the therapy side. But if we could get the risk stratification right, imagine how Vera's experience would change if we could truly predict the risk of specific outcomes. The risk of a heart attack, the risk of osteoporosis, and I mean real prediction, not of the kind where you look at an image and you predict it's a dog. That's not a prediction. The thing is a dog before you say it's a dog. And that happens all the time. To me, that's classification. That's not prediction. And so if we can predict risk, we can take proactive action. And the action bit is as important as the prediction bit, because unless you tell me the action, I'm not interested in making the prediction. So to tie all of this together, we have this thing which I call a program for AI in healthcare. It is not a center. There's no website, there's no executive director. If you Google for it, you won't find anything. The goal is to bring AI to the clinic safely and ethically, hopefully in 3 to 5 years. And the central anchor for this is this notion of what I call a prediction-action loop. Without the action, the prediction is useless. I can give you 10 predictions about all of you right now standing on stage, all of them perfectly useless. Unless you have an alternative action to take, don't bother making a prediction. All right, so let's dive into this. Now, I believe that AI and machine learning, they're different, and Jonathan in the morning clarified how they're different. They can help us advance the science of medicine, the practice of medicine, and the business of medicine, the delivery of health care. And it's really important to recognize that there's 3 separate things. Because a lot of times we pretend that if we advance the science of medicine, we will advance the practice and the business. If that were true, cancer should have been cured by 2010. Because that was a Genome Project promised in the year 2000. And so the things that machine learning can do in this little table are in the rows. You can diagnose or classify, you can predict or have a prognostic problem you solve, or you can have a therapeutic problem to solve, as in you recommend an action, and you can do that in the realm of science, the practice, or the delivery. It's good to have this grid. I mean, it's not perfect. Obviously, you can find use cases that will violate this grid. But it's important to be clear where one stands. And I'm going to be talking to you about advancing the practice, particularly by making prognostic models, and we'll focus on identifying patients who are at the risk of dying in the next 3 to 12 months. Okay, so now I just put that example up there, and how did I pick that? How did we arrive at that? And let's drill down. So this began with a conversation about palliative care with our chief of palliative care, Stephanie Harmon. And I was shocked by this map. Trust me, it has nothing to do with politics. This is about the quality of palliative care in the United States. Red is bad, blue is good. And the numbers are shocking. That about 90% of large hospitals with more than 300 beds offer palliative care. About 8% of admissions are thought to need palliative care, and about half of them get it, or less than half. And when you survey people and you ask, how do they want to pass, most people say they want to die in their home, surrounded by family. 75% of death happens in the ICU. Something is wrong. You don't need big data to tell you that there's a misalignment here. And so before even building a model, the conversation with Stephanie was like, what do you worry about? I don't ask what model she wants. The question is, what does she worry about? The worry is that they will be called too late into the conversation, usually 2 to 3 days before the patient actually dies. All right, so that's the problem. And then we quantified the problem. So in the current pool model for palliative care, which is the bedside clinician, the treating physician has to invoke a consult. This is how good we do. So about 131,000 people have died at Stanford Hospital in the past 18 or so years. It's not last year. And this is the code for palliative care. We're right at the average, just a little bit better. We're at 3.55%. Statistically significant difference, by the way. So if I have to prove that we're better, I can prove we're better. But if I ask the real question, how many people get offered palliative care 6 months before they die? It's terrible. And we have RCT-based evidence that when people are offered palliative care, they have a better quality of life, they live longer, and they cost less. So the action is eminently clear. All right, so now I'm interested in building a model. So what do I want to do? So let's say these are the charts that need to be reviewed to flip the palliative care model from a pull to a push model. And there would be a process that would flag charts of people that may benefit from palliative care. That's what I want. I could just hire a nurse or a staff member whose job it is to read the charts of 80 people who get admitted every day and make the list of people who might benefit. And that would be a perfectly viable solution. It would cost about $200,000. I think I can do better with a model. And then the human in the loop aspect would be that the palliative care physician then makes the decision about, should I follow up? And there's lots of issues involved. The patient might be a false positive, or it might be that the treating physician is somebody who's not receptive to palliative care calling them. Don't be surprised, it does happen. There might not be the right circumstance in terms of enough time spent in the healthcare system for them to meaningfully engage. So all of that takes about 90 seconds after a chart review to make that implicit judgment call, and another 17 minutes for her to try to track down the treating physician, for the two of them to jointly decide, should we have a conversation with the patient? Okay, so now I know these costs, I know what actions are going to happen. Then we get to a model. So here's a patient timeline. Here's a time point at which I'll make a prediction. We have some observation window, and we have lots of experiments telling you how much observation you need and what data density you need and how does that affect your prediction and so on. And then here's the key piece, your action window. Because if I make the prediction 24 hours ahead, it's pointless. I can be extremely accurate 24 hours ahead. If I make it 2 years out, it's also useless, or even 1 year out is useless, because people are not ready to engage in that conversation. So there's this sweet spot, 3 to 12 months. The 3-month is because that the gears of the health system need that much time to turn to schedule a consultation and a conversation about advanced directives. Now that's terrible. It should be a week, it should be 2 weeks, but it's 3 months right now, it's 90 days. Okay. So that gives me my desired operating constraints for Stanford healthcare system. In a different healthcare system, it could be something different. So we build a model. That's the easy part. What I'm showing you is a precision recall curve of a gradient boosted tree and a logistic regression, a calibration plot. We have ensemble models, we have deep neural nets. There's something called continuous probability risk score estimation, so that it gives you accumulated probability. Models are not the problem. So right, we have a model. And the way this works behind the scenes, we have a data warehouse on which we train. I get data nightly from the hospital. We run the model, we write the results back, and a report goes out every morning at about 6 or 8 a.m. to Stephanie. All right, so we have a model. Great. What next? Typically, in a clinical audience, the question I get, can I explain the prediction as an interpretability? And I refuse to do that. I refuse to do that till they answer this question: what would their intervention be? Because interpretation of the model is useful for debugging what's going on, but not always useful for deciding the downstream action. I'll give you an extreme case. There's a paper that I'm on where we're making 24-hour predictions of mortality. And you get an explanation from an algorithmic process that analyzes the deep neural net and its activation, and it explains to you that this particular person is flagged to die because they have metastatic lung cancer, they have a pleural effusion, they have bed sores, they have septicemia, and a bunch of other things. I can't fix any of that. So unless I know the action, that kind of interpretation of why is a model making a certain prediction is not very helpful. Then I want to know who dispenses the intervention. I want to know how does it affect the doctor-patient relationship. What are the mechanics of dispensing the intervention? What's the capacity? Because I can tune my model thresholds to flag 10 cases or 50 cases. And everybody is really interested in the positive predictive value of the model. And let's do this as a live poll. I have about 5 minutes left. How many of you have done a Google search in the last 24 hours? Okay, great. How many of you, what's your best guess at the positive predictive value of a Google search? 80s, 90s? Who thinks it's about 90%? Who thinks it's below 50%? One taker. It's about 0. I kid you not. Because the positive predictive value is, if you search, you get some results, about 100,000 or 200,000. The top 3 are relevant, so that's the true positives. 3 divided by 100,000 is 0, with 2 digits of rounding. But your attention span, your capacity, is top 3 links, maybe the first page. So what matters is the positive predictive value at that cutoff, the system capacity cutoff. And so it's kind of useless to optimize overall PPV. What matters is precision at K. What's the threshold for action? So that translates to how many false positives can there be in the top K predictions? Because I can have an overall PPV of 80%, but what if my top 20 predictions are wrong? It's an extreme situation, but it could happen. And my capacity to act is 20. So then in the top 20, it's all nonsense. What performance measure do we use? The agreement that they thought it was useful, or some cold hard metric like accuracy in F1 measure? What outcome should we track? The actual consult rates, the time between advanced directive setup and death, the rate of advanced directive setup, or just the percentage of increase in in-home deaths, or something else? Like, without answering these questions, I don't even want to begin building the model. And I'll just take this off the table. Where do we deploy and all of that? That's not the hard part. I mean, it's logistically hard and complicated, and you got to knock on doors and agitate and do stuff like that, but that's the easy part. All right, so then for this palliative care model, we answered all of these questions, and I kind of alluded to some of the answers along the way. And then the last bit is the utility, safety, and ethics. And I say last, but I'll bring it back as to why it's not last in the chronological sense. So utility, I asked the question, is it clinical utility or operational utility? In this case, it's clinical utility. Operational utility can be had in terms of bed capacity management and so on, but you need a different kind of prediction. Then there's concerns around safety, model correctness, interpretability, and the fiduciary responsibility. And then we get to fairness, equity, and the most important thing, the autonomy of decision making, or how much discretion are we giving up to the model. In this case, there's 2 humans in the loop. And I don't even show those humans the probability that the model outputs. They have a set that they're supposed to take action on. I turn that set into a list, and I don't show them the probabilities. Because in terms of what needs to be done, what outcomes we need to affect, and what problem needs to be solved, the model is a sideshow. If it was a 3-variable equation that had the same effect, totally fine with it. That kind of AI is also great. And so when you see a model, here are the questions I urge you to ask. What is the kind of use case at hand? So I gave this little grid of diagnosis, prognosis, therapeutics, practice, delivery. I took out the science column in here. Who will decide on the action to take? That's the most important. Without knowing that, it's not worth it. There's so many situations where a model gets built and then you take it to the stakeholders and none of them has any idea what to do. And I'll give a cartoon example, like a 30-day readmission model. Pretty much every health system has it, and they have no idea who to show the prediction to. Maybe the ophthalmologist? I don't know. Who should we show the prediction to? And then what assumptions are being made about the existence of an alternative action? Many times you just don't have, you cannot even ideate an alternative action. What are the assumptions about the need for interpretability? Because interpretability, at least in my mind, is one of 2 things. Either they just want you out of their office and say, just go away, so you invoke interpretability and then it's a can of worms and end of conversation. Or second, it's actually a request to say, prove it to me that the thing works. It's phrased as interpretability. Because clinicians use things they have no idea how they work all the time. But they're proven to help. Therefore, they use it. And then the incentives and the ability to take action. You might have an alternative action. You might have crossed the interpretability hurdle. but you have no ability. You don't have the extra people to take on those appointments. You don't have the scheduling ability. You don't have the patient's phone number to call them. It takes Stanford about 7 days to track somebody down. So I bring it back to this one-line mission. All of these efforts are to bring AI to the clinic safely and ethically. And they have to happen in parallel. Like English language, I have to write them out in sequence because there's no, unless you believe in Arrival, that movie where you have concurrent language, it has to be sequential. And so we work on building new technologies in partnership with technology companies, novel AI models. We deploy to the clinic, which is what I showed you today. With Abraham, we've thought about safety and how to keep the human in the loop. And then we also worry about ethics. My only New England Journal of Medicine article is about ethics of machine learning, which is kind of crazy. And with that, I'll end. And I don't know, I think it's a panel or questions. And here are all of the other stuff we do, but these are just other models, not important. This is what matters, right?
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.